Welcome, everyone. Thank you for joining us for Lenstar Cornea Map and complex surgical cases with Doctors Warren Hill and Stephen Safran, and a special warm welcome to members of iConnect International. My name is Genevieve Fay. I'm the head of marketing for Haag Streit US and your host for this webinar. A couple of housekeeping notes. For questions, please use the Q&A feature and not the chat feature as shown at the bottom of the screen. Questions will be taken at the end of the presentations. And please note that this webinar is being recorded for future viewing. For a disclaimer, the opinions expressed in these presentations and in the following slides and videos are solely those of the presenters and not necessarily those of Haag Streit. Haag Streit does not guarantee the accuracy or reliability of the information provided herein. First, it's my pleasure and honor to introduce Dr. Warren Hill. Dr. Hill has been in private practice in Mesa, Arizona since 1985 and has devoted most of his incredible career to challenging anterior segment surgery and the mathematics of intraocular lens power calculations. He's best known for his work in helping physicians around the world to obtain accurate IOL power calculations for their patients. His formula websites, including drhill.com and the ASCRS post-refractive surgery calculator, are two of the most popular IOL power calculation resources in ophthalmology, with nearly 500,000 visits per year. He's delivered over 28 named lectureships and presented over 740 clinical papers at national and international meetings in at least 42 countries. Today, he'll be presenting the new Cornea Map, Enhanced Decision-Making for Toric IOLs, and assessing the ocular surface for improved measurement accuracy. Go ahead, Dr. Hill. Welcome.
Okay, thank you, Genevieve. And let me get started here with, I'm going to share my screen, and let's hope we get everything working here. Okay, let's get rid of that. Okay, is that looking the way it should, Genevieve?
Not yet. I'm sure it's coming.
Okay, okay, so let's go ahead and get started. We're going to talk about some new software available for the Lenstar. And those of you who are Lenstar users, you know that this is a trusted friend. It has many features that we've grown to love over the years. And one of the great things about Haag Streit, which anybody who's ever used Haag Streit equipment knows, is that they are very good about supporting equipment. If you buy a piece of Haag Streit equipment, basically your grandchildren will be using it and it'll be supported. And the Lenstar is really no exception. And I'm excited to share with you some of the new software features for the Lenstar that keeps it from becoming a legacy instrument and probably one of the most valuable things you're going to have. So Genevieve,
You're all set. Yep, you're
okay.
up.
Okay, but we're not. I'm not advancing here. So, okay, here we
There
go.
you go.
All right. So, as we all know, Haag Streit is one of the oldest companies in ophthalmology, and they're continuously committed to finding ways to make things more accurate for all of us, and in anterior segment surgery, really consistent outcomes. I'm going to go through some of the basic features of the Lenstar just as a refresher, and then we're going to talk about some of the new features. So we have the highly accurate axial measurements, and this is actually the measurement head here. We have the usual white light measurements, the white to white pupil size and angle kappa. It has the best keratometry, period, of any biometer around. And it's good keratometry because it's a high density measurement process. We're not talking about extrapolation between 3 measurement points above and below the horizontal. We have 32 measurement points. And we're going to introduce now a corneal map and a method for ocular surface assessment with 30% more measurement points for topography and also validation. And the great thing is that there's no hardware changes. These additional measurement points come with your instrument. They've always been there. And now we're just going to be showing you how we use it. So let me just go through some of the real basic aspects. This is the axial measurements of the device. And it's basically in a familiar format of an immersion A scan. There's our ACD, central corneal thickness, lens thickness, vitreous, the optical axial length, and there's usually a 200 micron distance between the internal limiting membrane and the RPE. That's what separates optical biometry from an immersion A scan. All the electronic calipers are adjustable, so if you have a really complex cataract and the software gets a little confused as to where the posterior capsule is, we can always put that in. And just to show you the detail of the measurements, we have a different color for each of the different measurements it does, and you can see that the resolution is really quite remarkable. For the white light measurements, basically we have the machine does multiple measurements. This is for the white to white, and it also does the angle kappa measurements as well. And actually, this is my eye. I did this a few days ago just to kind of see how accurate it was. Every one of the measurements has validation criteria and standard deviations that we can use to make sure that the measurements are correct. Now, because we have about 30% more measurement points, we can use this to our advantage, and we can leverage this to give us an idea how good the measurements are. And why should we assess the ocular surface? Well, when we do keratometry, we're looking at reflected light. And a truer statement has never been said. A measurement is only as accurate as our understanding of what it represents. You want to get out of the habit of just pushing buttons and accept everything at face value. And just a reminder, for a 21 diopter lens, a 1 diopter error at the corneal plane is a 1 diopter error at the spectacle plane, but that's a 1.5 diopter error at the plane of the capsular bag. And our current standards for accuracy are plus or minus half a diopter. And if we don't pay close attention and make sure that the measurements are correct, let's say somebody has an unstable ocular surface or a very dry eye, it's really easy to get outside this range. And for those of us that develop IOL power calculation methods, the keratometry is one of the areas where it's really easy to get into problems. So now we have 48 measurement points. We have 3 rings. And I'm just going to share with you how we use those. So when you do the keratometry, you get this reflected image, and you're going to get 6 sets of 4 images, and you can just scroll through them and look and make sure that we have equal brightness and size. There's measurement consistency, and if any of the measurements look wrong, we can just repeat the measurements. But it's real easy for the case to be wrong if you've got an unstable ocular surface. And so these would be good measurements here, where we have a low standard deviation. And again, Haag Streit has provided a validation criteria in terms of the standard deviation for it. So this would be an unstable ocular surface. We have, missing images, variable size and intensity, and measurement inconsistency. We need to know that we may even have to bring the patient back, because if the Ks are going to be wrong, our calculations are going to be wrong. And for this particular case, the standard deviations are a little bit high. And also, in between measurement 4 and 5, there's a 1 diopter difference. So it's real easy to get things wrong if you have a funny ocular surface. And this would be just motion artifact. We may be unaware that patient was having a saccade or looking away. And you can see this very nicely. So some assessment of the ocular surface on which the measurements are based is really critical for us to be confident that the measurements are correct. And anytime we see motion artifact, of course, we repeat the measurements. Now, if you have a Lenstar, you're very familiar with the keratometry, and it's the part that we just love so much about this machine. This part has stayed the same, except that we've added an axial curvature map, and I'll show you how this curvature map works. And it's very, very useful for the toric IOL. Our office was part of the phase 3 study for the Acrosoft toric, back in the early 2000s. And actually, I was the author of the Acrosoft toric calculator. So we go back a long ways with toric IOLs, and we just love them. So let's say we're looking at the right eye here. Here's some Ks. If we click on the Ks, what we get is the images on which the keratometry is based, and we get 6 sets of 4 measurements. So that's 24 individual K readings. And if we click on one of the K measurements, then you get this map, and you can work your way through all 6 measurements. And if one, let's say measurement number 5, has some smeared images, it doesn't look good, you can just uncheck it and just take it out of the play. And what you want to do is have a correct standard deviations for the meridian less than 3.5 degrees, and for the keratometry a quarter diopter or less. So you can just uncheck the measurements that don't look right. So if the patient blinked or looked away, just uncheck it and use the ones that look good, and it'll give you very, very good results. And these are the standard deviations on which the validation criteria is based for the instrument. And this would be as somebody who, maybe has basement membrane dystrophy or an unstable ocular surface for whatever reason. Maybe they had LASIK or radial keratotomy. And it turns out that if you have a poor quality measurement, say, let's say measurement number 1 doesn't look very good, you're going to get these caution triangles right next to it. So it'll help you decide if these are measurements that you want to use. And you probably would uncheck the ones that have a caution triangle. And if you have a lot of them, basically, you might want to just do the measurements over again after you optimize the ocular surface. And let's go on here. Okay. And so these are some examples of, in measurement number 1, we've got a motion artifact, we've got unequal intensity of the reflected images, we've got missing images and smeared images. And so these are Ks that we really don't want to base our lens calculations on, especially if we're thinking about a premium IOL. We want to make sure that we have the best measurements possible. So as the carpenters say, we measure twice and we cut once. Now, because we have 48 measurement points now, we can generate an axial curvature map. So right now you're probably using the iSuite I916, and in May there was an update for the I917, and that activates the third ring of measurement points, and also gives us this very clever corneal map. And everything that comes from Haag Streit is just wonderful, and this is really a good example of how much time and thought Haag Streit puts into things before they introduce it to us. And I'm going to show you how this works, and it's really nice, especially if you use the toric IOL. So here's an old and trusted friend, the Zeiss Atlas 9000 topographer. And when we think about the toric IOL, we're really interested in the central 3 to 3.5 millimeters. What happens at 6 and 7 millimeters really isn't going to influence us too much for a toric IOL. So it generates an axial curvature map in the area of interest for the toric IOL, and it also draws a line where we have the steep meridian and the flat meridian. And this is very, very helpful in determining if these are correct. So this would be an example of an Atlas 9000 map. Here's the central 3 millimeters, and then this is what the Lenstar generates. And then it draws these lines for you. It'll show you the steep meridian, flat meridian. And if you draw a line through the corneal vertex and the center of the two astigmatic lobes, where it intersects the axis scale in the periphery, is by definition the steep meridian. Can't be anything else. And it's really nice to make sure that this kind of manually determined steep meridian matches the keratometry. So how do we use this for toric IOL planning? Again, the central cornea is really what we're interested in. And I'll just kind of review how my partners and I look at a cornea for a toric IOL. So this is the patient that we wish, always walked into our office, and we want to say to ourselves, is the power distribution suitable for a toric IOL? So is it regular and symmetrical? And we're looking at the central 3 to 3.5 millimeters. So ideally, the astigmatism should be regular, which means we can draw a line through the corneal vertex in the center of the two astigmatic lobes. And it should be symmetrical, which means we have similar power distribution on either side. But again, it's the central part of the cornea that really matters for the toric IOL. And yes, we can do irregular asymmetric astigmatism like keratoconus or unusual post-LASIK eyes. That's a completely different discussion and with a completely different set of rules. But here's just some examples of what the corneal map looks like. And these are all, by the way, these are all my patients. This isn't some marketing exercise. These are patients from my practice and that of Yuri McKee. And you can see how lovely these central maps are. This is oblique astigmatism, and then this would be against the rule astigmatism. So we're concentrating on the part we really care about for the toric IOL, and it gives us a really nice image. So So basically, as we talked about, what's the orientation of the steep meridian? We're looking at the central 3 mm. We draw a line through the corneal vertex, the center of the two astigmatic lobes, where it intersects the axis scale. That's the steep meridian by definition. Now, the Lenstar software does this for you, which is really fun. So this line is automatically drawn. And I'll show you some examples here. And then the other thing is, does our keratometry match what we know to be the steep meridian? So, before we even looked at the Ks, we have three important pieces of information. Is the astigmatism regular? Is it symmetrical? And what's the steep meridian? Very, very important. Now, if we look at the Ks and the steep meridian on the Ks lines up with what we know to be correct, we're on a very solid footing. And here we have 2 diopters is the amount of astigmatism, we're looking to correct. Okay, so back to our measurement summary page here, where we can click on the axial curvature map, and what you'll get is you'll get the reflected images. And here we've got a really nice looking cornea. We know that these are going to be very solid K measurements. We have the line drawn through the corneal vertex in the center of the two astigmatic lobes by the software for us. And it says 92 degrees on the Ks, and it's 92 degrees on the axial curvature map. So we know that these are measurements you can probably put in the bank. So that's our steep and our flat meridians. And we're just going through this. Okay, let's talk about the ocular surface again, because this is something that's, in my opinion, it's ignored by a lot of ophthalmologists. There's a little bit of a disconnect between the staff and the surgeon. The staff is kind of pounding people through the clinic and doing the measurements, and the surgeon may not take a look at it. Steve and I both, we spend time with our technicians, but a lot of surgeons don't. So let's talk about how this works and how it's very, very robust. So I specifically took some axial curvature maps of my own patients that had a funky ocular surface. And if we look at the central 3 mm with this new central curvature map, you can see how obvious it is where the steep meridian is for the toric eye well. And we'll just go through a few examples here. So there's our steep and there's our flat meridians. Here's another kind of unusual one, and you can see the central corneal map really defines these nicely for us. Here's another one with an obvious, this patient had basement membrane dystrophy. You can see that the axial curvature map is giving us a really nice representation of what it is we need for the toric eye well. Here's another one, with an unstable ocular surface. There's our steep meridian. There's our flat meridian. So when we concentrate on the central 3.5 or 3 mm, which is what we care about for the toric eye well, this all becomes a lot easier to visualize instead of trying to figure it out from the regular Atlas 9000 topographic map. So kind of putting it all together, we've got some Ks. These are very robust Ks. These are Ks that we all have grown to love with the Lenstar, with the 32 measurement points. And it's high density, and these are unique in all of ophthalmology. They're still the best Ks in the business. And we have validation criteria for the steep, for the meridians and for the power. For the meridians, it's 3.5 degrees or less, and for the power, it's a quarter diopter or less. We have the ability now to look at the reflected images in a very meaningful way and make sure that all the reflected images are correct. And if not, it gives us a heads up that we can go ahead and repeat them until we get something that looks good. And as I said multiple times, a measurement is only as good as our ability to know what it means. We want to get out of the habit of just pushing buttons and accepting everything at face value. Now we have a little bit more information to know about the quality of the measurements. And then we have this 3 mm axial curvature map that allows us to concentrate on the central cornea and gives us really good information that we need, instead of looking at like all the way out to 8 mm for a toric eye. Well, that's not really helpful. And then it automatically draws the line for us for the corneal vertex, the center of the astigmatic lobes, and we can see that it lines up with the numbers on keratometry, and we know we're on a very solid footing that way. So this is kind of exciting. If you use the toric eye well like we do, you've really got all the tools you need to do a wonderful job. So basically, just in summary, we have, highly accurate axial measurements, no issues there at all. All the required white light measurements, high density keratometry, still the very best in the business. We now have 30% more measurement points that generates these lovely topographic maps, and we can do an assessment and validation of the ocular surface. We have this high resolution 3 mm axial curvature map, which we can use for the toric IOL and not get distracted by a bunch of stuff that's going on in the periphery that we really don't need for the toric IOL. And we get a steep and flat meridian that's displayed and validated, which is, part of the really important information of what we need for the toric IOL. So I'm excited about this. Usually when there's a software update for a biometer, you're kind of unaware of what's going on. This is something really meaningful, and it's exactly what you'd expect from our friends in Switzerland at Haag Streit. So we love it, and I hope you're going to like it as well. Thank you.
Okay.
So I'll stop sharing my screen here, Genevieve.
Sure. Thank you so much, Dr. Hill, for that
Sure.
insightful introduction. And now I am equally honored and excited to introduce Dr. Stephen Safran, who's going to talk about complex cases, surgical cases. Dr. Safran currently practices in Lawrenceville, New Jersey, and has a special interest in complex cataract surgery, lens exchange, and endothelial keratoplasty and iris repair. But he also performs a broad range of glaucoma, cornea, vitrectomy, and plastics procedures on a regular basis. He has written many peer-reviewed articles and has been a cataract editor for iWorld. He's been an invited guest at many ground rounds and national and international meetings. His YouTube channel, which I suggest you take a peek at, has over 200 videos on complex anterior segment surgery and has been viewed by thousands of surgeons. He receives referrals for complex anterior segment surgery cases from all over the world on a regular basis and has pioneered many new surgical techniques. So, Dr. Safran, I'm going to hand this over to you.
All right, thank you. I'm going to go ahead and share my screen. Can you see everything?
Yeah, looks good.
Great. All right, so I'm going to talk about how I use the Lenstar to manage complicated cases. Warren has talked about a specific aspect of the machine, but there are many things that this does, and I want to kind of show how I use it in my clinic on a daily basis. Now, in my practice, I get a lot of referrals for cases like these. These cases include dislocated lenses that have to be fixated or replaced, sublux cataracts, socked-in anterior chamber lenses that need to be removed, and they may also have compromised corneas, areas of scleral thinning, filtering blebs I have to work around, and iris damage that needs to be repaired. So, there's a lot of things that have to be assessed. Many of these patients come from pretty far away, and there's a lot of information that I need to gather to make complex decisions. Bringing these folks back may be difficult or impossible, so I don't want to miss anything that I need. So it's important to get the information I need in the proper sequence. Now, quantum physics tells us that just the act of observing things, just by watching, the observer affects the observed reality. And we see this in ophthalmology in that the act of examining the patient alters and affects what we can see. For example, once you dilate the patient, you can no longer determine normal resting pupil size or check for an RAPD. And once you muck up the ocular surface by taking the pressure or putting drops or anything in, you really don't get accurate readings, keratometry, that reflect what you want to see. So I always meet and examine every patient before any drops of any kind are placed in the eyes. I want to see them before they've been dilated in their natural state. But even before I do that, my techs run new patients coming in for evaluation for surgery on the Lenstar. We want to get this data before the ocular surface is disturbed by the exam, and if we don't get this at the beginning of the visit, it may not be possible to get it done accurately at the end of the exam. And there's a tremendous amount of data gathered I can review right from the beginning to gain insights about the patient's situation and the type of eye that I'm dealing with. Now, what this gives me, Warren already told you, is extremely accurate keratometry, 32 data points at two different optical zones, 1.65 and 2.3 millimeters. I came out of an IOL Master 500 when I got my Lenstar with 6 data points at 2.3 millimeters. The Lenstar was 32 data points, so it's just a whole quantum leap above. And even the IOL Master 700 has only 18 data points for Ks, so this is really, as Warren said, I mean, I believe the Lenstar Ks are the best in the business. All of the biometers, will give you good axial length measurements. They all do that, and the Lenstar is very accurate, and it tells me a lot about the kind of eye I'm dealing with. When I look at a patient who's had surgery, I want to know, is this a 19 millimeter eye or a 29 millimeter eye? Because there's a big difference in every little aspect of what I'm going to do based on that. It gives me pachymetry, anterior chamber depth, pupil size, white to white, angle kappa measurements, and angle alpha measurements. And I look at these images for information. Now, the iris barycenter is equivalent to angle alpha. And what that is the difference between the center of the limbus, right here, the red, and the visual axis, which is the first Purkinje image. And it gives you that in both X and Y. The pupil barycenter is equivalent to the angle kappa. It's the difference between the center of the pupil and the visual axis. Here's the center of the pupil. Here's your first Purkinje image, which represents the visual axis. And in X and Y parameters, this gives you your angle kappa. So here's a typical patient. A patient referred to me unhappy with a multifocal lens in their right eye. But the left eye hasn't had surgery, and if we look at the left eye and we look at the pupil barycenter image, which is angle kappa, we see that both the X and Y numbers are high. And Jack Holliday says that if you add these two numbers, ignore the signs, just add them up. And if it's over 0.6 millimeters, this patient's a poor candidate for a multifocal lens. So just looking at the phakic guy, that might give me some insight as to why the patient's unhappy with the multifocal lens in the right eye. So let's look at a few cases. These are all cases from my practice. Most of these are recent cases. This one we just saw a few weeks ago, month ago. This is a 76-year-old referred status post bilateral surgery with PanOptics 6 months earlier. He's very happy with the vision of the right eye, but feels the left eye is just off. It's blurred at all ranges. He's got a similar refractive outcome in both eyes. Both eyes +1 minus for half at 155 in the right, +1 1/4 minus 1 at 15 in the left. But even when I refract him, no matter how much time I spend on it, he doesn't achieve a clear 20/20 in the left eye. It's just not quite clear. Even when I put the trial frame in front of him, it just seems off a bit. His OCT is normal, his cornea is clear, his ocular surface is fine. Of course, he's been treated for dry eye, but there's been no improvement. His lens looks well-centered to me, looking at the slit lamp, but is it? The pupil barycenter gives us a clue as to what the problem is here. If you look at the center of the pupil and you look at the visual axis, he's not looking through the center of the lens. He's actually looking through one of the first rings of the lens. And we see that the IOL is actually decentered relative to the visual axis in the left eye. And we see this in all of the images. We get 5 images, and all of the image, you can see that the visual axis is not passing through the center of the lens. So this lens is really not centered relative to its visual axis. So how do we calculate the new lens in this eye if we're going to do something about this? Well, normally we take the old IOL power and the refraction and plug those into a regression formula, Barrett RX. But that doesn't really work that well for a decentered IOL because the patient's not looking through the center of the lens. So what I do is I measure with the Lenstar in pseudophakic acrylic mode, and I take, pre-op AC depth and white-to-white measurement, AC depth and lens thickness measurements, and plug that into these formulas. And he's got a 15.5 lens in there now, and it says he would be about 0.73, which is very close to his spherical equivalent in his refraction. He's plus 0.75. So when I look at the numbers, a 17 diopter lens is what he needs, and it's a toric lens to correct the residual astigmatism he has. And so I feel very comfortable with this. So after a long discussion with the patient, I said, well, I think we should probably do a monofocal lens. He goes, no, I really want the multifocal. And if If I don't like it, you could take it out and put the monofocal in. I said, well, okay, as long as you're willing to do that, we can give this a try. So this is what happens when I take him to the OR. You can see there's a relatively small rexus opening. And what I'm going to do is reopen the capsular bag with dispersive viscoelastic. This is using a LASIK cannula. It's sort of my standard technique. And because this rexus opening is small, I don't want to try to fight to get the lens through the rexus opening. I'm just going to cut this haptic here and just keep on cutting right through the lens, right in the capsular bag. So I'm within the bag, I'm going to cut the lens within the bag, and now this half of the lens comes out very easily. This haptic, now I can pull that out. The second half of the lens comes out very easily. And I'm going to go ahead and put in a CTR here because I think that might give me some extra stability and keep the lens from decentering within the bag. I'm going to place a multifocal toric lens. I used a different brand of lens here. I thought I might have a little better management of any decentration. And this is the end of the case. Day one post-op, he's 20/20. The lens is very well centered. He's very happy with this. You can see the lens is centered in the pupil. And the pupil barycenter image confirms he's now looking dead through the center of the optic of this lens. So this is a very nice confirmation compared to pre-op. Here's an interview.
The problem before the surgery was my vision was blurry for distance and for close-up.
How about now? Most of those problems resolved?
Resolved much better now.
So the vision's much clearer now?
Much clearer, yes.
Yeah.
Yeah.
All right, so then you're happy with this?
Oh, yes.
All right.
Very happy.
Great, thank you. All right, great. So that's nice validation. Now, this is a 72-year-old. This was a few months ago. This is referred from a couple hours away with count fingers vision and a cataract in the right eye. He had trauma as a teenager. He used to have good vision, or so he says, in this eye prior to the cataract developing. His cell count is in the low 600s in this eye because he had some surgery done on it when he was younger. So how do we get accurate biometry on this guy? I mean, this is what he looks like. Well, we're just going to have to measure him dilated. So this is his dense PSC cataract. And here we can see when we measure him, the iris barycenter image. Here's his first Purkinje image. Here's the center of his limbus, the center of the cornea. So we trust that he is looking in the right place. The axial length is similar in both eyes, which is reassuring. But the anterior chamber depth is greater in the right eye than the left, which does suggest that he may have zonular laxity in this side. The Ks, which you see here, suggest that he's going to need a toric lens. And I like the fact that it's similar power in both eyes and that the axes are kind of pointed at each other. That makes me feel pretty good about what we're going to be doing for this guy. So how do we plan the surgery on him? He's got zonular laxity, low cell count, decentered pupil. Should we stage it or combine it? And how to create a central pupil? Well, this is what I did. I took him to the OR. And first I make some paracentesis and place some iris retractors. And I like to use Vision Blue in all these cases to stain the capsule. I get a feel for what my zonules are like. He's got a pretty dense cataract, but I chop it and phaco it. Irrigation aspiration goes well. And I feel that the bag is stable enough that I can just sort of put a CTR in to equilibrate the zonular forces, put my toric lens in and sweep for lens epithelial cells, clean that up. I'm going to remove my iris retractors, and now I'm going to bring the pupil down as much as possible with Myocal and stroking. And the way I'm going to recenter this pupil is to cut the pupil on each side with a micro scissor to release the tension that's pulling it over to the side. I'm going to cut and recreate the pupil to center it. So I'm going to suture these two flaps together, and this will recreate the pupil centered over the IOL in the center of the lens, which is where I want to put the pupil. So once I've closed that, I can now close this defect by bringing one flap over the other flap. It's sort of like a plasty of skin where you move skin over, and you can see that the pupil is nicely centered. This is an iPhone camera photo in the recovery area. And 1 month post-op, this is what he looks like. He's 20/20 -2 uncorrected. The cornea is clear. And the patient actually said to me, doc, this is a miracle, a true miracle. And, this is why we do these cases, for this, great gratification we get from the patient and having achieved a good result and something that when you first look at, you really don't know what you're going to do. And then when you pull it off, you feel pretty good about it. This is a patient referred unhappy with vision, right eye, after cataract surgery with an eye stent and YAG capsulotomy. Has been done in both eyes. He's got a 28 diopter, she does actually, a 28 diopter lenses in both eyes, but the right eye is minus 250 and the left eye is minus a half. There's this big refractive discrepancy. So I measure both on the Lenstar and pseudophakic mode, and what it tells me is honestly that both eyes should be pretty similar with that IOL. They both should have a similar refractive outcome. So what's going on? Why is the right eye so myopic? The 28 diopter lens that's in this eye calculates to a minus a quarter outcome, but instead she's minus 250. The vision's not very clear, as you can see from the simulated optotype, and the pressure is still high. She's got a pressure of 35 on a prostaglandin agent. So what's going on here? Well, when we look at the OCT, the angle, you can see that she's got a closed angle, and this is actually chronic aqueous misdirection syndrome. So we treated this with aqueous suppression and cycloplegia. The pressure came down into the high teens, but the patient remains unhappy with the poor refractive outcome and cloudy vision. So when I look at her on my OCT, I can see, looking at the retina through the camera, that she has all these floaters floating around. So this sort of makes me think, well, maybe I can kill two birds with one stone. After 2 years observation on max meds with a borderline pressure, I made a decision to do an iridozonular hyaloidal vitrectomy. So here we've taken her to the OR. And in this case, I used a 23 gauge vitrector. Probably now I would use 25 gauge. I put my infusion line in, my trocars in, and because it's a tiny eye, I don't go 3.5 millimeters back. I go like 2.75 millimeters back. These are those floaters that you saw. I'm going to do a complete vitrectomy and try to create, the goal here is to create a unicameral eye so that she doesn't have aqueous misdirection. Once the vitrectomy is completed, I'm going to bring down the pupil, put the infusion in the anterior chamber, and now from behind, I'm going to eat right through the posterior capsule and take a piece of the iris and create a unicameral eye. Well, the refraction changes from this to this. Patient notices a marked improvement in clarity, and you can see that in the optotype images. There's a reduction in higher order aberrations. But I measured the effective lens position, the IOL position, and this is pre-op. You can see that the aqueous depth, which is, the anterior chamber depth minus the cornea thickness, is 2.51. After the vitrectomy, it's moved all the way back here. And that's the reason that her refraction has changed when you take a 28 diopter lens and move it that far back. The angle's opened up. Its pressure is now in the low teens on 1 drop of timolol. Do I have time for one more? I'll present one more case. There's a 59-year-old male attorney, real estate developer, surfer from California. He's sort of one of these, guys who does everything. He's a master of the universe type, was in a car accident, and he has a sublux lens, vitreous in the anterior chamber, phacodenesis, a fixed dilated pupil that transilluminates, a large zonular dialysis. This is what his eye looks like. He asked me, how many of these have you done? What's your success rate? How soon after surgery can I go surfing? And then after a 3-hour consultation, he sends me this email with all these questions. This is the actual email, which I cut and pasted. And then this email: is there any way to assess the risk benefit to various outcomes, including traumatically negative outcomes? I'm like, perhaps you should consider a second opinion. He's like, no, Steve, you're my guy. I want you to do the surgery. So for my surgery on July 19th, do we need to make any decisions about the lens type preference? Please advise. Thanks, Bob. Well, this is the actual email. We did discuss all of this at your visit. I mean, I spent a lot of time with them going over all of this. The plan was to put in an eye-hands toric, a monofocal, give him a little extra depth of focus, target low myopia. I didn't want to use a multifocal on him because he was glare averse. And these are my measurements, and you can see this is what the plan was with the toric lens. So he comes in from California. We put him under anesthesia, block him. I get him in front of the microscope, and I see this. And what's that? Bob, have you had LASIK? Oh yeah, I remember I did way back in the 90s. Forgot about that. Is that important? Well, he's blocked and I'm scrubbed, and he came in from California for the surgery and he's received sedation. So now what do we do? Should we cancel the case? What I did was I broke scrub and logged into the Lenstar on my laptop and just recalculated him, putting in the numbers, assuming that he had previous LASIK using the AC depth and white to white from the previous eye. And now he doesn't even need a toric lens because that was actually the posterior cornea astigmatism that he had was corrected when he had his LASIK in the refractive outcome of the LASIK. So we just can use a standard monofocal lens. So we take him to the OR, and he has vitreous in the anterior chamber. So the first thing I'm going to do is stain with Vision Blue and then stain with triamcinolone so I can see the vitreous. I have my trocars in place, and I'm going to use anterior infusion and posterior vitrectomy to remove this vitreous because I want to push the vitreous back and remove it from behind. Be very careful not to hit the lens, obviously, with the vitrector. So now I'm going to make my capsulorhexis, and as I do this, I get a very good feel for what the status of the zonules is. And I center the rhexis on the lens, not on the pupil, because the rhexis you want to center and the lens itself in these cases. I'm going to place capsule retractors through paracentesis. I angle these down about 30 degrees so that the tips are parallel to the iris plane. Put them in the equator of the bag, and now we have good stability to do our phaco. When you do create support for a lens like this, you want to put the suture in the area of maximum zonular weakness. So I like this Malugan modified single piece Sione CTR. I make a couple of sclerotomies, 2 millimeters posterior to the limbus, connect those with a scleral groove, undermine the groove to create a little flap, reach in and grab each half of the suture and pull each half of the suture out through the respective sclerotomies. Now I can put my lens in, and the lens goes in the bag nicely. And when you tie these sutures, any little extra bit of tension will pull the whole complex over to the side. So you want to just make it so that it's slightly snug and under the surface, but not so tight that it pulls everything over. The vitrectomy is now completed. That's all triamcinolone staining the anterior vitreous. You can see that the lens is very secure, and this is important because we're going to do a cerclage. And once we do a cerclage, we're not going to be able to really see what's going on. We want to know that that lens isn't going anywhere. And the key to doing a cerclage in these cases is to place all your bites very tight next to each other and to switch hands and use your other hand to wrap the iris around the suture, which is a CIF4. The cerclage is completed. I remove the trocars. This is what he looked like 1 week post-op. He's 20/20 uncorrected. The pupil looks like this. Here's his refractive outcome. And he sends me this nice note. Hi, Steve. Hope you are well. My eye looks incredible and is doing fabulous well. Probably better than before the car accident. Thank you, Bob. So there was one more case. I think I just wanted to make one more point. If you have an unexpected result after cataract surgery, please remeasure the patient on the Lenstar post-op. There may be a significant change in Ks and sometimes even the axial length from pre-op measurements. Keratometry shifts in the post-op period are most common in post-refractive patients. We see this a lot in the RK patients that have flattening of the cornea, which can lead to progressive hyperopia that lasts for months. LASIK patients can be labile and unpredictable changes in the post-op period, and you may need to wait a few months to really understand the final outcome. Contact lens wearers should be kept out of lenses for extended periods prior to surgery, and make sure the contact lenses are out at the time of measurement, because that's a mistake that I see happen every now and then. My own staff makes, and I look at the case and I say, these aren't right, and take the lenses out and remeasure a week later. Axial length changes are more common in axial myopes. They may be more common in Marfan's, megalophthalmos, and patients with abnormal collagen and connective tissue disorders. If there's postoperative hypotony, you see a transient shortening of the eye leading to hyperopia, and IOP spikes can cause increased axial length myopia. This is a 36-year-old investment banker with a history of Marfan's, sudden loss of vision in the left eye. He actually had cataract surgery and bilateral iris sutured lenses in California 14 years earlier by Sam Maskett. And the lens in the left eye, he's gone. He's functionally aphakic. The lens was on the retina. So I did a pars plana vitrectomy, removed the old lens, and did Yamani of the new lens. And this is what he looks like 1 week post-op with the new lens. But he's 2.5 diopters hyperopic of target. His pressure's fine. He never had hypotony. His effective lens position looks fine. The lens is sitting where it's supposed to be. So let's take him back to the Lenstar and remeasure him. So these are his pre-op measurements. It's saying we needed a 20 diopter lens. These are his post-op measurements. The Ks haven't really changed. They're pretty steady. But look at his axial length. His eye is now 1 millimeter shorter than it was pre-op. And it says he needs a 23 diopter lens. So this is his pre-op measurement. He's aphakic, 595 pachymetry. There's his spike, and that's his axial length. And post-op, 1 week, pseudophakic, PMMA, just a tiny bit thicker cornea, 10 microns. That's his axial length. It's 1 millimeter shorter, decreased from 24.67. So this actually explains his hyperopic outcome. So let's wait it out and see what happens. 3 weeks later, he's only 1.5 diopters hyperopic. He's about halfway home. And we followed him for about a year, and he got most of the way back. I've seen these kinds of axial length shifts in many cases, mostly scleral fixated lens, but also on some routine cataract cases. And it may be more common if there's hypotony, post-op, but I've seen cases where there's no measured hypotony. And usually these eyes will slowly regress back to pre-op axial length or close to it. So if there is an unexpected refractive outcome with your lens, please repeat the Lenstar measurements. Changes in Ks or axial length from pre-op may be noted. Wait for stabilization prior to planning any surgical revision. You want to understand, why did this happen? And then before you do anything, make sure it's stable. And the point is that the Lenstar may actually be an equally valuable diagnostic tool post-op as it is pre-op. I can tell you that it is for me. So I'm going to just finish up here. In summary, the Lenstar provides the most accurate K measurements for IOL surgery we have available. I mean, these are best in business, and that's really what's most important to me, because all of these devices give good axial length measurements. The axial length measurements, of course, are just as good as anything on the market. They're excellent. But there's a lot of other information that you get about pupil size, pachymetry, white-to-white, angle kappa, angle alpha, anterior chamber depth. It just gives you a very good overview of the anatomy of the eye that you're going to be working on. And it's really as valuable a diagnostic tool post-op as pre-op. So thank you for your attention. And I'm going to stop sharing my screen and open this up for discussion.
Great.
Yeah, I might make one comment, and I hope that Steve and I aren't unusual, but one of the things that kind of unites our practices is that we work with our staff in the measurements. So I have my IOL calculation lady's been with me 16 years. We still do the measurements together, and it's not that I don't think she does a good job. It's just that sometimes she teaches me, and you have to stay close to the ground on these things. And the more you do, the better you get, and the more insights you have. And I think Steve will agree with me that sometimes the absolute correct answer can turn on a single piece of information that could be easily overlooked. And so doing the measurements with your staff is really good. And I'll just say it, one more time. Get out of the habit of having your staff just push buttons and ask for the next patient. I mean, a measurement's only as good as our ability to know what it means. And we have all these tools right now that allow us to validate the measurements. We have the validation criteria. And if you don't have them, you can contact Haag Streit in Ohio and they can send them to you. And sometimes just looking at the numbers, something doesn't seem right or something isn't correct. As they say, you measure twice and you cut once. And one other thing that we started doing about 2 or 3 years ago that has really transformed things for us, and if you track your outcomes, I can guarantee you this will give you probably another 3 to 5% increase in the accuracy of your half diopter outcomes, is optimizing the ocular surface before you do biometry. Our patients who have cataract surgery, they're elderly, and I live in the desert, so a big surprise, everybody has a dry eye. But what happens is when you do a topographic axial curvature map, all those little small steep and flat islands, they go away. The measurement to measurement variability on keratometry goes away. And the patients even comment, gee, my vision's so much better. So we do warm compresses twice a day. And what that does is it releases the lipid-rich secretions of the meibomian glands, which are crucial for stabilizing the ocular surface, lid scrubs in case they get some junk, from all this, and then frequent high-quality tears. We've been using biometry, sustains pretty good. TheraTears also works. But if you do the biometry with an optimized ocular surface, it's almost a different animal for some patients, especially people with membrane dystrophy or prior refractive surgery where they've had a flap and the corneal nerves have been cut or they have RK. So these are just some things that have made a big difference in our practice and we continue to do.
I
Thank
agree with
you.
what Warren
Yeah.
said. Yeah, I agree with everything Warren said. I have a two-tiered practice. One of my patients who come in from all over for complex cases, they fly in, I see them, and we do the surgery the next day. And so we can't, really take too much time on those patients, sort of one and done. But I have my own local patients, and very often we'll do exactly what Warren says, tune them up. Sometimes we have to scrape them, get rid of the anterior basal membrane dystrophy, do superficial
Right.
keratectomy, and just wait for things to heal. And I tell the patients, look, you're invested in this. It's, going to be what's in your eye for the rest of your life. I don't really want to do a lens exchange on one of my own patients if I can avoid it. I can do it, but I don't want to do it. So, we always try to tune them up as much as possible. And I'm actually a control freak. I like to sit in front of the Lenstar, click a few times, look at the numbers. Very often, that's how I sort of think about the case as I watch those numbers generated. I'm looking at the AC depth and saying, why is the AC depth 1 millimeter less in one eye than the other eye? What's going on with the zonules? Have you ever been hit in the eye? Why are the cases so flat? Do you ever have LASIK? Oh, I had something done. Yeah, I think I did. Well, yeah, I mean, these things come up as you look at the numbers being generated. You can see that, there's a lot of irregularity and not reproducible. And you can see that then you can go back and look specifically at the ocular surface, stain them with listamine green, and get a better idea of what's going on. Because it's a lot easier to address these things before surgery than after surgery. Once you've done the surgery, you own it. So I like to take care of this as much as possible before we touch them.
Yeah, and I think for both Steve and I, the thought process begins with biometry, because as anterior segment surgeons, how are we judged by our patients and our peers? We're judged by our refractive outcomes. They don't care how perfect the rhexis is or whether or not our incision's exactly correct. They care about, am I minus a quarter, plus a quarter? That's what they care about. So the thought process really begins with biometry. And if you can get in the habit of doing what Steve described, it really takes you closer to the ground and allows you to begin thinking about what you're going to do with these patients. And as I mentioned before, sometimes the solution and the good result can turn around a single piece of information that you notice. And you may want to repeat the measurement, or you may want to think more deeply about what it is you're going to be doing.
Thank you. Thank you both so much. We'll start our Q&A session, and we already have some questions waiting for you both. The first question is to both doctors, and the question is, what does your clinic workflow look like for toric patients for measurements, and is there anything to watch out for? I know we've talked about dry eye. Should we start with Dr. Hill?
Yeah, sure. And that's one of the great things about this new software update is it really enhances workflow, because right at the biometer, you've got every piece of information you need. You have validation of the steep and flat meridians. You can look at the axial measurements. You've got the software right there to do the calculations. And a lot of people don't realize, but we have multiple toric calculators on the Lenstar. You've got Barrett, which is, of course, an old and trusted friend, but there's also an artificial intelligence toric calculator written by Doug Koch, myself, and Adi Abulafia in Jerusalem. And so it's the Hill RBF Koch Abulafia calculator, and it just does a really good job as well. So pretty much everything's right there for you. So the workflow is pretty nice. Anything additional, Steve?
Yeah, I mean, I like to also make sure all the ducts line up. I mean, we have our topography, we have the auto-refraction, we have the Ks from the auto-refractor, we have the Lenstar measurements, and they're all sitting there. And I want to make sure that the ducts line up, the topography is regular, there's nothing funny going on. And then I look at this and I can start examining the patient, and make sure that, everything is consistent. Because when I do the toric lens, I want to make sure, is this somebody's a face sleeper? They have asymmetric astigmatism, coma, all of these things, keratoconus, you're thinking about these things. And you want to make sure that whatever you put in is going to be based on reproducible measurements that reflect the patient's constant state. You make sure that they're out of contact lenses long enough, that their ocular surface is tuned up. But, when the ducts line up, when the topography axis and the Lenstar axis, the Ks and the refractive axis and what they're wearing in the glasses, when all that lines up, it's very, very confidence inspiring. And in my practice, I tend to like to overcorrect against the rule of astigmatism a bit, and I tend to undercorrect with the rule of astigmatism even more than Barrett formulas and the Koch, the Abdulafia Koch formula would suggest to do, because patients are going to go more against the rule over time. So I like to sort of plan ahead for that, and I tell patients it's sort of like setting a watch that's losing time a little bit ahead so that it goes right past the perfect time, and 10 minutes instead of being 5 minutes behind, it's 2 minutes behind. So, that's sort of the way I like to do it. But there are many ways to do this, I think. My workflow is very slow. I'm very old-fashioned. I'm very hands-on. It's just, I'm limited because I'm solo practice and I don't have any optometrists or other doctors. So I see every patient undilated and dilated myself. But, I get through them and I like doing it that way. It's the way I do it.
Excellent. This one's for Dr. Hill. How can you tell the difference between poor osmolarity and movement on the LED display?
Well, yeah, sure. That's a good question. So basically, is it an unstable tear film, or is there movement? Usually with movement, you're going to get image duplication, you'll get smearing, and the whole thing will be smeared. If it's an abnormal osmolarity, what you may get is some part of the ocular surface looks funny and other parts do not. So usually an ocular movement, all 48 of the images are going to look weird. That's the typical way you do it. And the nice thing is you have 24 images to look at. You've got 6 sets of 4, and you can just click through them all. And if one set of the 6 doesn't look right, uncheck it and then go on to the next. And usually you'll have 4 or 5 sets of images that are correct, and you're on a solid footing and you're good to go. So at least you have that luxury of being able to pick and choose which images your Ks are going to be based on.
Great. And this, we probably take one more question. How do, either doctor, how do you measure the posterior cornea, or, and do you use SIMCs?
Well, the Lenstar doesn't measure the posterior cornea, so that we don't do. With
Is that a concern of yours, or?
Well, go ahead, Steve.
Well, the Barrett formula uses algorithms to estimate the posterior cornea, and it's based on many different factors, including anterior cornea curvature. He's basically come up with an algorithm, and it turns out that the algorithm is very, very close, if not just as good, as actually measuring the posterior cornea in the reality of using the lenses that we're using, which come in rather large depths. So the total K versus the Barrett formula, I haven't really been impressed that is, with the steps and the toric lenses we're using, really that critical a factor. Again, especially since, we're using these 75 or 1 diopter step toric lenses, and I'm actually trying to overcorrect against the rule and undercorrect with the rule anyway. So I, basically try to ask myself, well, what the patient going to be most happy with if I overcorrect or undercorrect that. The Barrett formula, again, does a very good job in estimating. Now, some of these eyes are funny posterior corneas, like if I'm doing a post-graft patient, all bets are off in some of these eyes. They can have weird posterior corneas. But, when you're looking at the garden variety patient, you're going to put a toric lens in. Usually there's about a half diopter of posterior cornea astigmatism that contributes to against the rule. That's usually about what you're going to see, what you're going to get. And Barrett sort of fudges that based on his algorithms, which are actually very good, very accurate.
Yeah, and actually the Lenstar has two algorithms. It has the Barrett algorithm, and then it also has Abulafia-Koch. And what's interesting is that these algorithms are actually one of the earliest forms of machine learning, because the algorithms contain more than just the posterior cornea. They contain a lot of other things. In artificial intelligence, it's what we call feature addition and feature extraction. As Dr. Safran mentioned, the areas where we want to use the posterior cornea is a PKP patient, somebody with a prior refractive surgery, somebody with prior trauma, something where the posterior cornea is going to be abnormal. And for that, you can, if you have a Pennicam, you can use that. And the Barrett formula, actually for toric IOLs, actually has the ability for you to enter the posterior cornea. And also there's a newer formula for prior refractive surgery. It's by TK Yao in Singapore called EVO, and that allows you to enter the posterior cornea as well. So, prior refractive surgery, PKP, keratoconus, these kinds of things, when we do the calculations, we do enter the posterior cornea, but we use specialized formulas. But as Steve mentioned, we've looked at entering the posterior cornea compared to using the algorithms. And with current technology, and again, that may change with some of the new OCT devices, the algorithms are as good as direct measurements of the posterior cornea or normal eyes. That's the thing to remember for normal eyes. And I think you can be very confident in using the Barrett algorithm or Abulafia-Koch. Both of them are really quite excellent.
Excellent. Well, thank you both very much. This completes our webinar. If we did not get to your questions, we'll follow up with you with an email. And I just want to give a big thank you to our presenters, Dr. Warren Hill and Dr. Stephen Safran, for your excellent presentations today. And thank you so much for joining us.
Okay, it's been a pleasure. Thank you.
Thank you. Thank you for having me.